Hey guys, I'm pulling double duty today. Got the baby with me today, so if you hear some coos or oohs or screams, I'll probably stop if I get some screams. But you might be hearing the baby chime in every once in a while. So today is an introduction to mechanical diagnosis and therapy. This is a presentation that I put together a few years back with the help of Mary Jones. She put some of the pictures in there. Again, not my thing. Again, thanks to Aldwin for teaching me how to record a screen. Finally, these are my views, obviously, not the views or opinions of the McKenzie Institute International. I don't represent them. I'm credentialed. I'll give you my history real quick. I was credentialed in 2010. I went to the study group at RIC from 2007 to 2010, and then I've been using MDT on a daily basis from essentially 2007 onward. Yeah, this is me, physical therapist. These are the objectives. You can go through this. This is actually a presentation that I gave. I don't make any money off of any of this stuff. I'm literally just trying to get the word out there, teach people about classifying back pain. And again, if you have any questions, you can feel free to ask. I won't go through the whole presentation today, actually, because it's fairly long. Probably going to go through about 5-10 minutes, maybe, or as long as the baby will let me. And so I've got her in my hand, so if you hear my voice changing, it's not puberty. Thanks. So Robin, he's an honorary life member of the APTA, and he is voted the most influential orthopedic physical therapist by the orthopedic section of the APTA of the last century. I highly recommend reading his book, Against the Tides. It's a good biography of what he had to go through in order to get this chance discovery that he made to actually educate people all around the world, and the help that he had getting to America, and some of the first patients that he saw in America with spinal fusion. There's some good stories in there, and you can actually see essentially the difficulties that he had trying to take this method that he created and move it forward. Some of the stats: roughly 80% of back pain, 80% of adults will have back pain, and then again, if you watch the last one, 70 to 80% will continue to experience back pain after 1 year. That may not be a recurrence. It just may be that the back pain never actually shut down. Yeah, back pain costs us a lot of money, and so we need to do a better job of figuring out how to treat it. A patient with low back pain has a 75% chance of having an abnormal MRI, but not all low back pain symptoms are related to abnormal MRIs. We see abnormal MRIs in asymptomatic patients also, and as you see here, you see bulging or protruded discs in over 50% of asymptomatic individuals. So just because the patient has abnormal imaging doesn't necessarily mean that the abnormal image is related to their symptoms. So MDT has been said in the research that it's the most useful method of treating back pain. And Danish physical therapists use MDT more so than any other methods when treating low back pain with radiating symptoms. I think at the time that I did this presentation, MDT was the most studied classification system for back pain. Some of the red flags, kids with back pain or over 55, you're looking at tumors, osteoporosis, possibility of cancers. And so these are the red flags that you got to look for when you see patients with back pain. A violent trauma or prolonged steroid use. Violent trauma, you're definitely looking at fractures. Prolonged steroid use weakens the bone over time. Past medical history of cancer. Past medical history of cancer is I guess it's the number one risk factor for a second occurrence of cancer. Some of the systemic symptoms: weight loss, generally unwell, fever, bowel, bladder, saddle, paresthesias. Oh, to give you guys just a little quick note as to where all this information is coming from. This information comes from the MDT textbooks from the lumbar spine. This is literally a book report of the first two books of the lumbar spine. You can find the book, I think, at opt.com. You can probably find it at amazon.com. They're not cheap. The first book especially is a rather boring read. It's a lot of statistics. But the second book is the bread and butter of the algorithm for the McKenzie method. So some of the red flags again: cancer, primary tumors are rare, secondary tumors are less rare. We see them specifically in the thoracic spine. If you go back on my page a little bit, you'll see that I did a case series of patients who were diagnosed with low back pain and sent to PT, and then they were later diagnosed as having cancer, so you can find that on my Facebook page. If the patient comes in with a deep-seated, boring, constant pain, lack of variability over time, worse at night, drives the patient from bed, these are the most likely red flags that you're going to see. And then, like I said, previous history is the most likely subjective finding for a secondary case of another case of cancer. Spinal infection, 1 per 250,000. Patient will be unwell, raised temperature, general malaise, night pain, night sweats, and raised ESR. You'd have to ask for that ESR, most likely. You're not going to get it. There's a new algorithm out that talks about if the patient has cancer. If a patient has a history of cancer, I don't have it in here because it's a newer study. If the patient has a history of cancer, you want to make sure you note that in your assessment. You might have to give the physician a call, especially if the patient's symptoms aren't making sense. And you might want to ask for an ESR. The ESR, if it's over 50, I believe, I don't have the research in front of me, but if it's over 50, you're looking at, hi baby, you're looking at bone scan is typically the next step. I'll try to find the research article. I cited it in one of my previous papers. And again, for spinal infection, recent or persistent fever, systemically unwell, severe, constant, unremitting pain, worsening overall, no loading strategy reduces symptoms. Fractures, typically seen in osteoporosis. The most common fracture sites are the lumbar spine, the femur, and the radius. This is an absolute contraindication to manipulation and mobilization techniques. You have a higher risk of fracture. These are patients that we typically go hands-off on, even though there is some research out there that shows that we could stimulate bone growth with a grade 1 PA mob. It more comes down to CYA than anything else, because you have to look at that cost to benefit. You know, the cost is a fracture for the patient. The benefit is you might make the patient better. And so that cost is kind of high. You want to minimize flexion and encourage extension. Additional deterioration was less in the extension group than the flexion group. This is one of the studies. I might have it at the end. If not, I'll try to find it for you. For this presentation, every student that comes through me for a clinical, they get these presentations to read prior to coming into me for the clinical, so that way they're aware of what types of patients they're going to see when they walk through the doors. Cauda-Equina syndrome. I've actually had one of these patients. It was an interesting case. I haven't done a case study, but I probably should. Patient came in, older gentleman, older, 60s, retired, fairly smart guy. And he was telling me that he was having bladder issues, and I was actually treating him for a shoulder. He was telling me he was having bladder issues, and then and they were seeing a urologist, and the urologist was not helping him much. He was still having incontinence, and then he also told me that he had back pain. And so while I'm evaluating his shoulder, I'm like, well, wait up here. Let's go through and look at some of the other stuff. He had bowel bladder issues. He had saddle paresthesias. I called the spinal surgeon. It was actually up in the ER. They got him in immediately. They did the MRI. Sure enough, he had Cauda-Equina, and did the surgery, and the incontinence cleared up immediately. Actually had numbness down the leg that he didn't tell me initially. It looked like sciatica, not the bilateral lower extremity symptoms that you typically hear with Cauda-Equina syndrome, but he had the sciatica plus urinary incontinence plus saddle paresthesias. That was an immediate call to the surgeon upstairs. Anyway, loss of anal or sphincter tone, impaired sexual function, absent Achilles reflex bilaterally, foot drop. He also had foot drop. Unilateral, bilateral sciatica, reduced lumbar mobility. And like I said, this demands an urgent referral. And so I called the spine surgeon, and I think he had surgery within a day. All of the symptoms cleared up except for the foot drop. Cord signs. So bilateral stocking paresthesias, you're going to get, some people don't know what that is. I'll be honest, I didn't know what that was when I first graduated from PT school. And that's numbness, tingling, pain down both arms, both legs. Non-myotomal weakness, hyperreflexia. Again, these are your central symptoms. Hyperreflexia, positive Babinski, that's where, gosh. So you can hear my baby every once in a while in the background. When she was probably 2 months, I was testing all of her reflexes, so I got to test the Babinski on her, just to see what it looks like, because it's rare to actually see that in the clinic. And so it was, you can YouTube them, but if you have anybody who has a baby, hey, this is your opportunity to practice. Ankylosing, positive Layer-Midi sign. Layer-Midi sign is what you typically see in MS. That's where if the patient flexes their head, they get this electric shock down their spine. You might see hyper or hypotonicity, and then that bowel and bladder dysfunction. Some other diagnoses that may cause you to reconsider this patient as purely mechanical, in one of the classifications, is spinal stenosis. Imaging is essential for the diagnosis of spinal stenosis. The theory is that you have a narrowing of the foramen, and extension would compress the nerves, and flexion would reduce the pressure. The clinical presentation is worse with walking, little or no pain at rest when sitting or lying, and flexion reduces symptoms. Extension is limited and may provoke leg symptoms. Some of the newer research now talks about assessing the hip and the thoracic spine, that maybe we can get around the limitations from lumbar extension by increasing hip extension and thoracic extension, range of motion and strength, so that way the patient doesn't have to extend through the lumbar spine when they're walking. Spinal stenosis, again, there's a study out there that followed a patient over the course of 10 years. Roughly, a third improved, a little bit over a half were unchanged, and roughly the same third worsened. So these patients may benefit from advice to avoid extension and use flexion-based activities, especially if their ADLs are greatly worsened, because they can't walk. For these patients, you may tell them to walk, slouched. If they're adamant against surgery or their medical complications prevent surgery, then it's on us to teach this patient how to reduce their symptoms and keep them reduced and maintain maintain function. And so we have to work on improving hip extension and trying to buy some flexion room for the lumbar spine. Hip problems, pain associated with weight bearing, and a report of easing or abolishing with sitting. This is the opposite of what you'll typically see for that posterior lumbar derangement. The pain pattern is the groin, anterior thigh. Sorry guys, this might be my last slide. My baby's getting kind of restless. You'll see groin, anterior thigh, knee, maybe anterior shin, lateral thigh, and possibly buttock. Pain provocation tests, passive or resistant movements. You're looking for that concordant sign. You're trying to figure out how you can reprovoke this patient's symptoms to determine whether or not you can assess the hip and find a directional preference for derangement, or determine if there's a dysfunction or a postural syndrome. MDT also works in the extremities. So, and actually I believe there's one study out there, I don't have it cited, it's a newer study, that MDT is more reliable in the extremities than it is in the spine. So, anyway, that'll be it for now. So to give you an idea as to what's coming, SI joint, facet, spondylolisthesis, non-organic, and then we get into how do we actually classify patients. Anyway, thanks for watching. I'll be back at some point in time. I'll do a Facebook Live if anybody wants to jump on and ask some questions. I'll try to do a Facebook Live. Maybe the baby will become a rock star today and movie star. Anyway, have a good day, guys.